Hi and welcome back to Conceptual OBG. Today I'm here to discuss one such drug that every single obstetrician and gynecologist uses every single day, and that drug is going to be progesterone. Now, this is a topic that has been suggested by a lot of you in the DMs over the last couple of months, and I decided that I'll make it in a way so that you all will be able to relate with the practice that you all have been doing in your clinics. So, when I talk about the drug progesterone, of course, it is one half of the sibling, that is estrogen and progesterone, that we have been hearing since decades about. But what is so different about progesterone, and why is it so crucial that no OBGYN can do without it? So to talk about the mechanism of action first, it acts, of course, we know it's a steroid hormone. So it acts through an intracellular um, receptor, which is going to go and bind directly to the DNA inside the nucleus. And once it goes and binds there, then it is going to cause MRA and transcription. And basically the changes are going to be derived from the DNA directly. So it is going to act directly on the DNA, and that is very crucial to know. So once it goes and acts, what are these receptors? So these receptors are progesterone receptor A and progesterone receptor B. Of them, the second receptor, that is the progesterone receptor B, is the most important one because it is responsible for carrying out all the agonistic activities of progesterone, whereas the other one, that is progesterone A or progesterone receptor A, is the one that actually causes progesterone resistance, or it inhibits the action of progesterone. So all the positive actions of progesterone are brought about by this second receptor, that is progesterone receptor B, and that is why a lot of these molecules which bind classically or specifically to progesterone receptor B give you all the positive effects of this drug. Now, what are the positive actions that I've been talking about for so long? Then first, we'll just go by the name. The name is progesterone or progestation. So it is something that is in favor of pregnancy. How? So this progesterone is going to come and it is going to bind onto the uterus. Once it binds onto the uterus, inside the myometrium, it is going to cause down regulation of calcium channels. Basically, it is going to block calcium channels and it is going to cause something called as uterine quiescence. What is quiescence? It is nothing but a quiet state. It is basically when the uterus is not having any activity. So it reduces calcium channels. It also blocks the prostaglandin receptors by a certain mechanism, and it ensures that the uterus doesn't contract. The uterus won't contract, the fetus and the placenta are going to be safe inside, and hence it is going to help the pregnancy get through these 40 weeks. Apart from that, this is the effect, as I told you, of progesterone receptor B. So during labor, I now actually need the uterus to start contracting. So the action of progesterone shifts from progesterone receptor B to progesterone receptor A, which, as I told you, has a bit of a opposite action, and hence that will lead to contraction of the uterus and labor will ensue. So there is a functional shift and not a pure progesterone deficit or a withdrawal that happens around the time of labor. It is just a shift from the action of progesterone receptor B to progesterone receptor A. What apart from that? Apart from that, not just the myometrium, but it also induces secretory changes in the endometrium in the second half of a menstrual cycle. So secretory changes are basically, it induces glandular growth, cystic growth, water is introduced, water in the glands is introduced in the endometrium, and it primes the endometrium to receive an embryo and cause decidualization. So it is very important for the progesterone to be there so that the endometrium can accept or be receptive to the embryo that is going to come to it. Apart from that, not just at the level of endometrium, but even at the level of spiral arteries, it helps in the neuromodulation, not neuromodulation, it helps in the modulation of for remodeling of the spiral arterioles. It is a very important factor. Not just that, it also shifts your immunity from Th1 to Th2, which is going to favor your pregnancy. Plus, it also prevents the mother's body from rejecting the fetus because it is an allograft, because it contains 50% of paternal antigens, and it prevents the rejection of it by down regulating several factors and cytokines, especially natural killer cells. So all in all, it keeps the uterus quiet, it primes the endometrium to receive the embryo, and it also ensures that the fetus is not going to be rejected and it can get through the pregnancy very safely. Apart from that, it also has an action on the cervix where it thickens the cervical mucus so that the cervix doesn't open up earlier. And not just that, it also maintains the length of the cervix to prevent premature labor. So all in all, an excellent hormone and excellent steroid that helps in ensuring that the pregnancy goes unscathed. Apart from pregnancy, is there any other role of using progesterone? Yes, several roles apart from just pregnancy. In gynecology, it is used for patients with secondary amenorrhea to cause withdrawal bleeding, or for the progesterone challenge test as we call it. Apart from that, in patients who are undergoing IVF cycles, then progesterone is a very important drug because it helps to give luteal phase support in the transfer, after the transfer of embryo has been done. So very important factor that. Apart from that, progesterone is also said to have a positive effect on epilepsy. It increases the threshold of epilepsy, and the action is through GABA A receptor, by the way. So it helps in having a positive effect on the neural component of the brain as well, which is also why they say that whenever you give DMPA, the number of episodes of epilepsy reduce marginally. So these are all the actions of progesterone, and now I'll proceed and tell you all about the drugs that are very important for you to know in progesterone. Several classes of drugs. Now talking about all the individual progesterones, so there is a broad classification that we have. The classification is natural versus synthetic progesterones. So in natural, you have ideally just natural progesterone, but there's a modification to it, and that is called as micronized natural progesterone, wherein they have made micromolecules of almost 3 to 5 micrometer, and they are then given to you. The most common name that you may have heard of micronized progesterone is going to be sustain, capsule sustain, that is given. So the micromolecules, because they are made very tiny, the surface area increases, and hence the absorption profile and the bioavailability eventually is much better than simple natural progesterone. But what does it do? So when I talk about natural progesterone, it is literally going to mimic your endogenous body wala progesterone. It is going to just mimic that. So when it mimics that, it is going to go and bind to both progesterone receptor A and progesterone receptor B. There is not going to be any sort of discrimination that is being done. Secondly, it is not going to have any glucocorticoid, mineralocorticoid, or androgenic concomitant effect, which I'll tell you about for other progesterones. So it is going to be a pure progesterone receptor agonist. And apart from that, because it's a progesterone receptor agonist, it is going to go and bind to them. All the actions that I mentioned on the uterus, on the fetus, and even on the neurological side are going to be fairly similar for micronized progesterone and natural progesterone. Now, when I talk about this natural and micronized, I also need to understand what is the dosing that is being given for them. So the dosing for micronized natural progesterone, as is recommended by several articles, is actually 400 milligrams orally, or even better if it is given per vaginally. So especially in cases with threatened preterm labor, recurrent pregnancy loss, or threatened abortion, and even for luteal phase support and all these things, this natural progesterone or micronized progesterone is better, the capsule, if it is kept in the vagina. The other preparations that you get apart from the capsule happens to be in the form of a depot injection. The depot injection is in the form of either oil, or nowadays you even get aqueous solution. Unfortunately, my experience has been that the oil preparation has a better action, although it is much more painful. But aqueous is less painful, but also not as efficacious as the oil preparation. So that is a major thing that you need to know. The other preparations that you get for this natural and micronized progesterone also is in the form of gel. You get gels that can be applied in the vagina or on the skin. And yeah, so most importantly, it is the depot preparation, the capsule form, and the gel that is available. A very good form, and I would say one of the best forms of progesterones that we have, natural or micronized natural progesterone. The second, and what comes near being the best, happens to be a retroprogesterone, whose also name is dydrogesterone. Now, dydrogesterone has several names. You may have heard of dufaston, which was one of the first molecules that I have used from them, and it is from the company Abbott. Apart from that, there are ones like Dydrogest, and several names, Dydrofen, there are several names to it. Earlier it used to cost a lot, but nowadays the rates have come down for it. Anyway, it is like a modified form of natural progesterone, although it is synthetic, but it goes and binds only and only to progesterone receptor B. Now, as I told you, progesterone receptor B is the one that is going to have all the agonistic activities. So this is purely a progesterone agonist. Again, it is not going to have any glucocorticoid or mineralocorticoid or androgenic action. But unfortunately, I would also say that it is not going to have the neurological action, or its myometrial quiescence action is a little weaker. But it is very good for inducing the secretory changes, the decidualization of the endometrium, and hence making it much more receptive for the fetus and the embryo that is going to grow. A very good molecule, a little expensive. What is the dose? So the dose that you give is going to be 40 milligram of loading dose. So 4 capsules of 10 milligram are going to be consumed as a loading dose, and then the maintenance dose is 10 milligram TDS, or if it is a little too expensive for your patient, then you can even give it twice a day. No role of giving it vaginally, only the oral route is very good for dydrogesterone. Excellent molecule, very low side effect profile, but also very limited uses as of now. Nowadays, they are also using it for hormone replacement therapy in postmenopausal women. There are studies that are coming in that are showing that it is a good drug, but not yet proven. So for now, I'll only use it and limit myself for its use in pregnancy. So that is all about dydrogesterone. Now coming to the next commonest drug or form of progesterone that you have heard. By the way, please excuse me, I have been having a very bad LRTI and hence I'm struggling a bit with my breath. So I'm shooting this video in a few parts and you might just hear me breathe heavily through it. So yeah, coming to the next drug, it is going to be a very famous drug. Again, I would call it a celebrity drug because everyone has probably heard of it, and that is Devry. Now, Devry, the pharmacological name is Medroxyprogesterone or medroxyprogesterone acetate. And before I talk about it, I would now like to tell you all about the generations of progesterone. So we have 4 generations of progesterone, and when I say generations, they are only and only for the synthetic progesterones, or what we also call as progestins. And the first generation has the highest androgenic activity, whereas the fourth generation is literally anti-androgenic. So it stops the androgenic activity that is going on in the body. So the side effect of the first and the second generation is that it is going to have a bit of androgenic activity, which is why I cannot use it in pregnancy. Otherwise, if the fetus turns out to be female, it can lead to virilization in it. I do not want that, of course. Whereas the fourth one, that is the anti-androgen, is very good, excellent for treating patients with hirsutism, hyperandrogenism, especially in PCOS, but again, cannot be given in pregnancy. Why? Because if it is now a male fetus inside, then it will go and induce feminization, or it is going to cause an effeminate appearance of the male fetus, and hence these synthetic progesterones are not used in pregnancy. So the first one, as I mentioned, is Devry, which is medroxyprogesterone acetate. What is the good part about it? It is quite cheap. And not just cheap, it has a very strong progesterone action. It goes and binds to the progesterone receptor very strongly. It also has a bit of glucocorticoid action. Not important, but what is important here is that because it has a very strong progesterone activity, it goes and significantly suppresses my gonadotropins, which are LH and FSH. So it downregulates my pituitary hormones, and hence it's a good drug to give if there is any follicular cyst in the ovaries. Apart from that, it also has an anti-estrogenic action, which is why if there is any hyperestrogenic state leading to endometrial hyperplasia, medroxyprogesterone acetate is in fact one of the ways of medically managing it. Not just that, even if the patient is having abnormal uterine bleeding because of some unknown cause, unknown is basically when you have ruled out fibroids, submucosal fibroids, coagulopathy, ovulatory dysfunction, everything, and you know that it is just that the endometrium is becoming too thick, then in that scenario, this progesterone, medroxyprogesterone, will go and thin or cause atrophy of that endometrium. So it has an anti-estrogenic action, but unfortunately the same anti-estrogenic action is going to be detrimental to the bone. So if you're giving it for a long time, it may start inducing those anti-estrogenic menopausal like changes, which will lead to osteoporosis. So we don't prefer to usually give it for anything more than 2 years. If I'm going to talk about medroxyprogesterone acetate, then there's something that should strike your mind, and that is medroxyprogesterone acetate. So depot is nothing but an oil preparation that we give in the buttock. It is a contraceptive agent. It's a long-acting reversible contraceptive. You give it in the buttock. The dose is 150 milligram. It works for 3 months. The return of fertility and menses might take up to 6 to 9 months, and it might lead to progesterone breakthrough bleeding in between, which is why it is not that convenient. Also, it is very painful, but a good contraceptive agent if compliance is taken into consideration. Again, cannot be given for more than 2 years. In fact, I recommend don't take it for anything more than 1 year, because bone loss has been seen on DEXA scans. So that is about medroxyprogesterone acetate. What is the form in which we get it? DMPA is of course an injection, intramuscular injection, but the MPA, that is Devry, is available in the form of a tablet. It is also available in the form of a sustained release tablet. I don't use it much. The maximum dose that you can give in a day is 30 milligrams. So you can give it in the dose of 10 milligram thrice a day as a maximum. Can't use in pregnancy because of its androgenic activity and very poor pregnancy protective action of causing uterine quiescence, decidualization. All of this is quite low with it. So not used in pregnancy. A good progesterone only pill, this can be used as a contraceptive agent because it is going to stop your LH and FSH and hence inhibit ovulation. Medroxyprogesterone acetate. The next one then is going to come Norethisterone and Levonorgestrel. Now, these drugs, especially Levonorgestrel, is something that you have commonly heard in OC pills or combined OC pills with estrogen. So it is one of the commonest second generation OC pill that you see. Mala N, Mala D, that you get for free in the government, also contains Levonorgestrel. In fact, your emergency contraceptive, your I pill, unwanted 7-2, even that contains a high dose of Levonorgestrel. How does it act? Very similar, although this has a bit of a strong androgenic action. It binds to the androgenic receptors as well. So if you're giving it for a prolonged period of time, it might start inducing a bit of androgenic effect on the female who's using it. How does it act? Again, strong downregulation of your gonadotropins, so your ovulation is going to be inhibited, and everything similar to medroxyprogesterone. It is going to have an anti-estrogenic activity which will lead to atrophy of your endometrium, so it treats your abnormal uterine bleeding. It can even be given for management of abnormal uterine bleeding and endometrial hypoplasia. So a very good drug, very cheaply available. The market available drug form of Levonorgestrel IPL is hardly 80-90 rupees. If you are taking a drug in combination with ethinyl estradiol, as in the form of an OC pill, then it is available for free in a government setup. And even out of that, you can still get it for 100-110 rupees for one cycle. So a very good drug, but unfortunately, very limited uses. And those limited uses are all for gynecological uses. Obstetric uses, you unfortunately cannot use it. Maximum dose that you can use, there is no upper limit for Norethisterone. The upper limit they say is 15 milligram, but I personally, in my practice, I use a drug called as Primolute N. I have used it till the dose of almost 30 milligram, but they say that beyond 15 milligram, that is 5 gram TDS, the effect is not that good. The effect is basically only androgenic and no progesterone effect is given above 15 milligrams. So try to restrict your doses till 15 milligram per day. Now you even get those sustained release capsules and tablets rather, which you can use for your patient for AUB, menorrhagia, or endometrial hypoplasia. So a good drug, Levonorgestrel, also useful for causing progesterone withdrawal bleeding. Norethisterone, Levonorgestrel, Norgestrel, first and second generation progesterones. Now, coming to the next one of those drugs which was given very commonly in pregnancy, but in the year 2022, the US FDA, the Food and Drug Administration in the US, has made it into category D, and hence the use in pregnancy has reduced. This that I'm talking about is a drug that you have used very commonly. You may still be using Prolutone as an intramuscular injection that you give weekly to patients with threatened abortion or threatened preterm labor, or as luteal phase support. It is commonly given. The drug name is Hydroxyprogesterone caproate. You have to avoid using it because they have said that there are a bit of androgenic changes that have been found in the fetuses, and hence prefer not using it that often. The dose used to be 250 or 500 milligram per week. avoid using it. It has been given a category D, that is use only if there are no alternative drugs available, because it may cause some teratogenicity in the fetus. So medroxyprogesterone, hydroxyprogesterone, caproate. All the main ones done, all the main ones discussed. Now I'll just come to a device, that is LNG-IUS, Levonorgestrel intrauterine system, or what you also call as a Mirena. So Mirena, excellent thing, one of the best contraceptive agents that you have. Once you put it inside, it stays in there for almost 7 years. It gives you contraception. Excellent for several purposes. It contains 52 milligram of levonorgestrel, and it leaves 20 microgram of LNG every day. It starts its action within 6 months, and the actions can go on for 7 long years. So good for contraception, good for treating endometrial hyperplasia, a very good endometrial protective agent in patients who are receiving tamoxifen for breast cancer, because it keeps the endometrium very thin. It doesn't let hyperplasia happen. Also good management for abnormal uterine bleeding. And of course, an excellent, one of the best contraceptive agents that we have, one of the highest Pearl indexes, or one of the best Pearl indices that we have. It is Mirena, or levonorgestrel intrauterine device. So this was yet another progesterone that we use in our daily common practice. And now the last progesterone that is left, which technically, as I had mentioned, is a class 4, so anti-androgenic drug, happens to be drospirenone or spironolactone or cyproterone. It may ring bells because you may have used it in patients who have hirsutism, PCOS, acne. Several brands are available. Yasmin is one of them. What is its use? So it is an anti-androgen. So a patient or a female who is obese, who is having PCO, who is having hirsutism, hair growth on face and all areas, you can use it in them. There's a caveat to it. You cannot use it for more than 3 months, because it is known to cause hepatotoxicity. So that is one thing that you have to remember whenever you use these drugs. These drugs can be given alone for the treatment of hirsutism, or they can be combined with ethinyl estradiol and can be given as oral combined contraceptive pills. But do not give it for more than 3 months, and do monitor the LFT every time you are giving these drugs. Give it once in a day. Do not overdo it. Very limited uses. Again, cannot be given in pregnancy because it can lead to feminization of a male fetus. Very important drug, but limited uses, mostly in cases of PCOS. These were all the drugs, all the progesterones that I have covered. There are a few drugs that have a both agonistic and antagonistic activity with progesterone. We call them selective progesterone receptor modulators. You have ulipristal and mifepristone in them. I have taken separate sessions for them on conceptual, so I wouldn't repeat it. The major use of it is seen in patients who have fibroids, or who of course want MTP. In them we use mifepristone, or in outer countries you even have ulipristal, which is being given as a emergency contraceptive pill in the dose of 30 milligram per day, or stat dose. We don't get it in India though, unfortunately, but it's a very good contraceptive agent which can be used, or rather post contraception, post conception, post coital contraceptive device, which can even be used up to 120 hours, unlike our levonorgestrel, which can only be used up to 72 hours. So good drug, but not available in that amount in India. Again, hepatotoxic, so you have to make sure that you monitor the LFTs whenever you're giving it. This was all about progesterone. Does it have any bad side to it? Does it have any side effect? So the side effects are mostly bloating and metabolic problems, like the patient is going to have a lot of nausea, vomiting, especially in pregnancy. The hyperemesis worsens for these women. So that is one of the very few side effects that the drug has. Apart from the androgenic and anti-androgenic side effects that might happen in a fetus, hence we do not use them in pregnancy. But otherwise, progesterones are fairly a safe drug that you can use for various purposes. So that is it from my end on this session on progesterone. I've covered almost everything, the doses, the routes of administration, everything. If you all have any doubts, comment in the comments. Just ask me your queries in the comments, and do let me know what are the subsequent topics that you would want me to discuss with you. This is Dr. Aditya signing off. Keep watching Conceptual. I'll be coming back with such reels every week.